at UCSF. Having come to us on the West Coast from the East Coast, she did much of her training at Sinai in New York, and then moved over to San Francisco for her fellowship and has stayed on. So we've collaborated on a number of projects, and I'm really excited to have her teach us a little bit about some of her passions. So welcome, Maya. Is she on? I'm just trying to find her. Okay, cool.
Thank you so much for the opportunity to join you and to join this wonderful group, and just congratulations for putting this all together. And it's just a really great resource and great topics. So yeah, excited to be able to talk about this important subject of advanced care planning and some other things that we had, suggested.
Yeah. So we're going to kind of hop around a little bit, which is going to be a little unusual, but I think you can follow kind of our thought process. Because I think, I wanted to have Maya speak on a few different subjects, and we've kind of been building a little bit on advanced care planning. So Maya, maybe first you could just tell us a little bit about how you got interested in neurology. I know you have an interesting background as a musician. Maybe you could teach us a little bit about that, and how you became interested in neurology, and then Parkinson's, and then also developed this interest in palliative care.
Sure. Yeah, so I spent some time as a violist in my early time, but never really, I always thought it would just be something for fun. But yes, that is a side story of mine. I did play in a jazz band in New York City and in a rock band as a rock violist, so it's true. There's probably some videos of it somewhere. Yeah, so I went into neurology and medicine. I'm a very compassionate nerd, basically. And so it really just helps kind of fuse those two things together. And then I went into Parkinson's as a specialty, really because I saw deep brain stimulation and was just really blown away by this incredible really intervention, a brain pacemaker that works. I still think it's the most fascinating and potentially effective treatment in neurology, and I'm still involved in that research. And then palliative care, I really was introduced to during my internship, which I happened to do at Mount Sinai in New York City. And so I learned that every patient should be seen through a palliative care perspective. So I think I just was lucky enough to do my internship there. And so it just kind of fell into place when I started my fellowship. They already had a palliative care clinic. And so it's just something that I was already pretty familiar with through my internship and residency.
So when you say that every patient should be seen through a palliative care perspective, can you teach us a little bit about that? Because I think that's a little bit unique to some of us, I think that. And I think some people are really worried about the whole word palliative care. They think it connotes something really negative and bad. So maybe you could teach us a little bit about that perspective that you learned.
Yeah, I think for me, I remember when I was an intern, the palliative care doctors would wear a button that says, "There's always something more to do." And I think it kind of counteracts this idea when doctors tell patients, "There's nothing more I can do for you. There's nothing left to do." And actually, that's never the case. There's always more to do for people. Even if there's so many diseases that we can't cure, delay progression or change the underlying process at all. It's not just Parkinson's disease, hypertension, diabetes, it's a lot, right? It's actually most diseases. But the idea is that, okay, so maybe you can't change the, what's happening in the underlying course, but you can always improve quality of life. And it's this idea in palliative care that we're not just biological buttons that need to be kind of adjusted, right? We are, as humans, more than our parts, right? We are spiritual beings, we are social beings, we are emotional beings, and we are physical beings. It is one part of our total health, and then also one part of the total pain, which is a concept in palliative care. Total pain, serious illness affects not only the biological buttons, the physical side, which is what we typically focus on in Western medicine, but also it affects our spiritual health, our emotional, our social health. And so there's always something more to do, to help people attain health in those other areas. And in fact, there's evidence that earlier palliative care in patients with serious illness actually extends quantity of life. So maybe if you improve quality of life, you can actually improve quantity of life. And that you don't actually need to ever choose between quantity and quality of life in healing. You can do both, and they can be synergistic to each other. So those are the concepts of palliative care. And I do think that they're applicable to any person dealing with any kind of serious illness at any time.
Absolutely.
But yes, I do agree. The P word has a huge stigma. It's associated with hospice. We call it the H-bomb because it's so devastating for people to even hear that word. And so because, hospice means there's, someone is in the terminal stage of their disease, it is a scary word. And that's where palliative care came from. It's just so equated with those two things that it's an incredibly scary word. And so that's why we really try to rebrand it. We rebrand it as supportive care. Who would like an extra layer of support for the stress of being sick? Everyone, right? Nobody's going to say no to that. So, but if you call it palliative care, people think, oh my God, are you sort of giving up on me? Are you throwing in the towel? It's a complete opposite, right? But the cultural kind of story of that specialty is real and needs to be acknowledged and respected. I think that the heaviness of that word is real.
Absolutely. And I think you and I have been involved in this initiative with some of the other folks that are going to be coming on, including Dr. Kluger, to find a space for neuropalliative care as a special, sort of field, and to cultivate that and develop a society around that. Can you tell me a little bit about your thoughts on that society and why it needs to exist, and how your thoughts are even about from the patient perspective as to why patients may want to get involved in that?
Yeah, so I think it's because palliative care is always, I like to think of it as medicine turned upside down, because it's saying, hey, we're not just biological buttons. Hey, we're, much more than our parts. Hey, it's really, connection is protection. It's this focus on all these different types of things. It's very much culturally almost challenging the norms. And so I think that it's it really needs to have a special place where like-minded individuals can really grow the society without the limitations of kind of the mainstream medical culture. And palliative care is the future. I'd like to say you don't go back and do less whole person care. Nobody learns about palliative care and is like, you know what, I'm going to practice more default medicine. Everyone gets the same thing no matter what, right? So it is the future. Once people learn about it and exposed to it, they're like, obviously that's how we should be taking care of people. But you need to have that place of leadership in a society and a journal and research, and to really be able to integrate into the mainstream medical culture.
That's really amazing. I don't know, Maya, if you can see any of the comments. You've spoken for maybe 5-10 minutes so far. Absolutely, Dr. Katz. Absolutely right, Dr. Maya Katz. Thank you. We had a bad experience with palliative care, and thankful we turned to the VA. I have never heard a medical doctor speak to the whole person like this. This is excellent. Thank you, Dr. Katz. I wish more physicians would talk with their patients the same way. I work for a hospice and palliative care program, and you put it very gracefully. So I think you're seeing here the patients and folks on the phone are speaking on the lines or whatever on the virtual land are speaking. I think that this is really special, and I think that it is. You said there's the default, so there's the standard of care medicine, and then I think there's the universe that is on the fringe that include most of the peeps that I am on this group of my favorite people in the world that are kind of think about medicine and moving the sort of needle in this other direction. So I think it's kind of a revolution, and I think we have to advocate for it from the ground up, and that includes patients. And I think a lot of what I'm trying to do with this sort of, not so great time that we're all in with COVID is try to look for the silver linings and look for a way to rethink, reset, and move forward. So I know you have some slides. Before we get into them, Maya, you work with a very special group of people, and you have a team that is in your palliative care group that is pretty fabulous. I'm going to be having one of your people on that I had the pleasure of meeting through you, Judy Long, who is a chaplain. Could you speak a little bit about who's on your team, why they're there, what they do, and, you know, maybe highlight one or two special pearls just from your team approach.
Sure. And I do, you know, some of these comments are really important, especially people that have negative interactions, you know, experiences with palliative care and hospice, and that I think it's an important thing to maybe address at some point as well, because I do want to comment to that. But so in our specialty neuropalliative care clinic for Parkinson's, there's a so I'm on the team, so I'm a primary palliative neurologist. Sounds like a made-up term, but it's the term that they're using. So that means I don't have any specialized training in palliative care, but I know what it is. I'm an enthusiast, and then I sort of am a specialist in symptom management. And a part of palliative care is, we call it aggressive symptom management. So they're like, oh, so you're going, you know, it's palliative care. I guess they're not going to do anything. Either you can pick aggressive care or palliative care. So actually, we like to think of it as we are aggressive. We are aggressively palliative. And so part of that is really being aggressive about symptom management. You can't think about the bigger picture of life if you're focusing on the day-to-day symptom burden, right? So that's one of the things. So I help with that. And then we have a palliative care doctor who has specialized training and can really help people identify their goals, their hopes, their worries about the future, really talk through these incredibly difficult, essential experiences of humanity, right? And so she can really help people understand, okay, with what we know now, we have this illness, it's affecting our lives. Okay, but that's not everything we are, right? We're not just our diagnosis, we're a whole person. Let's get to know that whole person, and how can we have meaning outside of that, right? And our whole person way. So that's the palliative care doctor. And then we have a chaplain. I think that, Indu, that's who you're referring to. And our chaplain focuses on spiritual care. And I like to think of that as, you know, connection to the greater. And so in palliative care, there's the concept of connection is protection. And what does that mean? That means that being connected to the self and what brings you a sense of purpose. We need a sense of purpose. We cannot just wake up, take our meds, poop and eat, and go to sleep. That will not satisfy our spiritual health. We need to wake up with a purpose and a goal. So she really sort of, you know, so that's sort of the connection to the self. And so helping us identify that. And then there's connection to family, connection to community, connection to nature, and connection to the greater, whatever that means for you. And so I think she helps people find that connection. And without that connection, we are lost. We cannot be truly healthy. And then she also really teaches coping skills, balance and resiliency in difficult situations. How can we still find a way to have some sense of balance, some sense of control? And that she helps people learn. And so those are really, really, you know, important skills, you know, when we're just facing day-to-day struggles. And then we have a social worker who helps people with the practical type of, you know, challenges, making sure they have all the resources they need, the financial stuff, the health insurance stuff, you know, assessing safety, you know, if people need extra equipment at home or something like that. So that's the team that we work with.
That's amazing. You're so lucky to have all those people. So I'm going to let you tell us a little bit about your advanced care part of your talk. And then I know that you're passionate also about some other specific symptoms, non-motor symptoms that we have in our struggles with Parkinson's. So we'll talk about those a little bit later on, but let's get to your advanced care slides.
Sure. And then there is someone who just talked about having a bad experience with palliative care. If I could just, you know, briefly talk about that. You know, I mean, it's palliative care is really a philosophical approach to medicine. Not everyone's going to practice it well. So that's what I would say is, you know, if there's going to be practitioners that don't practice it well, and it sounds like maybe you had that. And so sorry to hear about that, but don't close the chapter to palliative care. You know, it's the same thing. You might need a kidney doctor. If you see one kidney doctor that doesn't help you, you don't close the book on all kidney doctors, right? So it's sort of the same kind of thing. So keep you know, just keep open to it. Okay, so I'm going to do the share screen, and oh, okay. that, sorry, I'm not the smoothest on this.
No, you got it.
Okay. 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 All right. So this is just our palliative and supportive care clinic. And we do see most of our patients through telemedicine. And that really helps because we can see people in remote areas. And, you know, if you're having mobility issues from Parkinson's, then it's just easier to see your doctor without having to, you know, take all the burden of the travel. All right. So this is actually a slide from Dr. Benzie Kluger, who's going to be talking. And I think it's, you know, it's a little bit outdated from 1996, but I do think that it is still accurate. So this is really why advanced care planning is important for everyone, right? And and you know, I've done advanced care planning. I've had my husband tell me what his wishes are. You know, when we cross the street every day, it's probably the most dangerous thing that we do. So, you know, we need to really think about and kind of, I think a part of it is that medical culture, we think death is optional in America, basically. And it's not, right? I mean, there's two truths in life, right? Death and taxes. So, and so I think that, you know, just sort of understanding that our life is limited and that really kind of, you know, coming to terms with it is part of that spiritual journey that each of us takes. And part of what our chaplain helps people work with is that kind of, you know, understanding of our natural process. But this is really, I think, just summarizes why advanced care planning is important for all of us to do. And so, you know, really sort of, you know, there's a couple of documents that are important. There's the Advanced Healthcare Directive, and this is available online. And basically, it has 3 different parts, but the first part is where you choose your medical decision maker. And really the idea is that you know, if you are too ill to speak for yourself, who would you want to be that voice? Who would you want to be that voice for you? And we ask people to pick a primary and then an alternate. If the primary is not available, who else would you want to speak for you and be your voice? I really encourage people to do this. You know, the whole Advanced Healthcare Directive. And I think probably choosing a medical decision maker is the easiest part. And so even if you're not ready to make any healthcare choices, at least just complete part 1 and then you're done. That's it. You've chosen who you want to be your voice. And it's important that with that person, when you're ready, you do have conversations about what kind of healthcare you want and what kind of healthcare you don't want, right? And so, you know, in part 2, make your own healthcare choices. That's where you would write down, you know, what we think about as goals of care. So for example, you know, what kinds of functions could you really not live without, right? So and it's really different for every single person. And I'm gonna give you an example. My husband loves video games. And he told me he could be sustained on machines for decades, as long as he can play video games through virtual reality. So as long as his brain's okay and he can just like delve into those video games for hours, he could be otherwise like hooked up to a million machines and it would be great. So that to me would be unacceptable. That's like, you know, I would be forced to play video games. So it's really important that every single person has their own definition of what's acceptable and what's not acceptable, and that you talk openly with your decision maker about what that means to you. Don't assume that it means the same thing as, you know, to you as, you know, it means for another person. Everyone has their own definitions of what's an acceptable quality of life and what is an unacceptable quality of life, right? And so I really, really encourage you to just look at these forms and start thinking about these things. I think the main thing is that, you know, as a physician, as a clinician, I want to give the kind of healthcare to my patients that they want. I don't want to give healthcare procedures to a patient that they never would have wanted, right? And they can't speak up and tell me that they don't want it, right? That's not good healthcare. The other thing is, you know, you have a right to control what kind of healthcare you get, right? Don't give up that right. When you make this form, you keep your right to decide what kind of health care. And the other really important part of this that I tell my patients is really filling out one of these forms. It's a gift. It's a gift to your loved ones, because you remove the burden that your loved ones feel if they have to make these decisions on their own. It's a tremendous amount of guilt. And so if you can talk to whoever you would want your decision maker to be and tell them what your wishes are, they can carry out those wishes. And the coping that happens when loved ones carry out wishes that they know, are really true and resonate with what their family member or, whoever they're making those decisions for would want. It's really a different process than when they're faced with making those decisions and not knowing what that other person would have wanted. There's a tremendous guilt. And so I, just have seen both scenarios in my family, personally, when people have expressed their wishes and when they haven't, and also clinically, right? And I know the difference. And so I want you to see it as a gift to your loved ones, to be able to give them just a path forward. People really want to have that path forward to help carry out someone's healthcare choices. And that's how I would see it. And then this is another form that's really important. This is called the POLST. And so the Advanced Healthcare Directive form just needs to be notarized or witnessed by 2 people. The witnesses can't be anyone named in your healthcare directive. It can't be anyone that will inherit from you. And it can't be anyone that works for your healthcare providers. But otherwise, it could just be anyone else or a notary. It is difficult now in the shelter in place to invite, notaries into your home and things like that. So it does make it a little bit more challenging. But if there's 2 witnesses, that might be easier if they're sheltering in place with you. So that does, but I think even starting this paperwork and thinking about this paperwork is really important. The POLST is different because this is a form that you sign with your physician. I'm wondering, has show of hands, and I don't know if I can see everyone on the screen, but who has seen this form or discussed this form with their doctor? Some people have. Okay. Some people have. That's good. So this is a form that's really important because it talks about those, if someone is really seriously ill, critically ill, life-threatening illness, they're not able to talk for themselves. They've talked about, with their doctor, what these different choices mean, and they've made some choices based on that. And this becomes a legal form that, paramedics have to follow, that hospitals have to follow. And so, it's really, this form is really important. If there are people that have very strong, wishes about this, some people say, you know what? So the first area is CPR, which is basically if someone has passed away, they're not breathing, their heart has stopped, they have passed. At that time, some people say, you know what, that's my time. Let nature take its course. It's allow a natural death. And then other people say, you know what, even though I know it's only a 5 or 10% chance to bring me back to life, try, I know it's going to be, very aggressive interventions to try to bring someone back to life, but try, and so those are really two big things, right? And so some people are like, I have no idea. Some people say, you know what, I've thought about this, and if it's my time, it's my time. If my heart stops and I stop breathing at home, it's my time. And so it's really important for people that have those kinds of really strong wishes that this form is completed. If you don't really have strong wishes and you just want to sort of think, you can talk about it more with your doctor, or think about it. But if you have very strong wishes about what kind of healthcare you don't want, if you have life-threatening illness or have already passed, this is a really important form for you to have. I'll give you an example. My great aunt was very clearly do not resuscitate. She was 95. She had a massive stroke. She absolutely did not want resuscitation or intubation. And when the paramedics came, we did not have this form, but we had an advance directive that was very clear. We had the family saying, if she dies, she dies. Please let her go. And they resuscitated her and intubated her in the ambulance. And so we had to then, you know, kind of help make sure that she was comfortable and that her wishes were carried out at that point. But because we didn't have this form, this is the one form that if we had had this form, they would have had to legally follow it. Otherwise, they can use their medical judgment, and usually they will do what is most aggressive. So I know these are really heavy, big topics. I mean, I just want to acknowledge that these are not easy things to talk about. And thanks to all of you for really kind of stepping over that hurdle and really kind of looking at this face to face and head on. But I'm just kind of giving you some real life examples of what happens, you know, when people, you know, don't have the correct documentation, even in cases where their wishes are incredibly clear. And so I encourage you to really, you know, complete these forms and really, you know, just for that type of impact. So this is just a little bit on palliative care. And I talked about how one of the concepts of palliative care is that's total pain. And so this idea is that it's not just about physical suffering, there's spiritual suffering, social suffering, and psychological suffering in serious illness, and that all these different aspects need to be addressed so that we can help people have the best quality of life. And then this, I think we're going to talk about afterwards.
Okay, that's perfect. So maybe we'll just pause there. So I wanted to just emphasize a couple things and just, you know, ask, you know, you if you wanted to emphasize a couple things after listening to what I wanted to say. So one thing, a lot of the people that are on the call are from all over the country, many from Arizona, because PMD Alliance is based in Arizona. So unfortunately, every state is different with a lot of these forms, which is, you know, an important point to take home. And so I think you have to make your own inquiries about what's available in your state. California has certain forms that are pretty amazing that may not necessarily apply to your state. So definitely find out about your own state, or I think people have been calling in from other countries on this call. It's been pretty cool. And so, you know, find out what the forms are in your own state, but in country. But I think identifying somebody to help as your surrogate decision maker is very key. And then the principles of these are going to be pretty standard. So, you know, filling out a form that is going to guide people. And if you the reason that, you know, it's important is that the default, usually we talked about the standard of care or the default is if the paramedics come, they're going to do everything unless they're told otherwise. And so that's why taking this opportunity, as you mentioned, to identify this and state it very clearly. If you're using a pulse form, it goes on the fridge, it's a pink form, the paramedics know to look for it there. And then communication is also very key. So, you know, a lot of us are thinking about these things now, we're really interested in them, and maybe starting the conversation, you know, going through a real conversation with your physician, having them help you to talk through it, and then communicating, say, you know, I have this form, who do I give it to at this point? If your family doesn't know what your wishes are, it doesn't really help you. If your doctors don't know what your wishes are, if you don't put those forms in a place so that if in an emergency something happens, then unfortunately the default in our current healthcare system is usually to do everything. And often what happens is, even though I'm in a VA clinic and I'm taking care of a patient, we may have talked about it, if they call 911 and they're out in the community, usually the paramedics will take them to the nearest emergency room. And there's often, you know, in that state of craziness, it's very hard for anyone to know where the forms are and who the people are that were part of the conversation. So I think taking those extra steps, if you have very clear a sense of what you do and do not want, and then having that ability to communicate it so that your wishes are ultimately followed is really the key, I think, of many of these conversations. And I think you putting some of these words into very beautiful statements. You're, you know, sort of talking about a gift of doing this advanced thought process, so that when in the sort of moments at these times when people get very sick, people are just really under duress, they're really under stress, they really can't make these decisions with a sound mind. And it's often very hard to know, what would my loved one want? And there's, like you said, a lot of guilt, a lot of other emotional stuff that gets mixed in. Sometimes multiple family members come into the picture and are all, oh, you know, battling it out. And it often is a very tough thing to witness as a healthcare provider. Many of us have seen this and also experienced it in our own families. So I think if you can give that gift of almost like a, you know, sort of a, a peaceful sort of state of mind in this process, because somebody's already made this decision for themselves in advance, then it's just, you know, a matter of having, you know, not these decisions thrown into the already stressful mix of what happens when somebody gets quite sick and is really in these situations. I think that's all really important. Maya, was there anything else you wanted to say about that?
Yeah, I did. Yeah, thank you for bringing up the state-by-state form. So there is a website called Prepare for Your Care, and I put the link in the chat box, and that includes forms that are legal in all states.
Great.
Yeah, so that's very helpful to use. And that, yeah.
Any other resources that you have, you can, you know, give us as well. I think, you know, they'll be able to link all of these in a place right underneath the video that we're going to have of this. So they're very, very good at organizing all these resources, and we can link anything. So that's great. So I think, you know, you spent a lot of time talking about the holistic approach to patients, and really, you know, seem like the type of doctor that has a very different approach than just, I see a tremor, here's a pill, see you in 6 months. So I think, you know, you're talking about things like advocacy of many, and almost like a revolution of thinking about health in a very different way, and thinking about how to approach health for our patients as a team approach, with really identifying things that make a difference for the quality of life of our patients. And I think this is very different than maybe what a lot of us were taught in medical school, at least with Western approaches. And I think we are trying to be passionate about teaching this to our medical trainees. I know you've been very involved in teaching students, fellows, and residents about the importance of this. And it's really inspiring to hear where people got inspired. And it sounds like you had an internship that really was a game changer for you for this. And so I think each of us has a responsibility to, if you have a good experience, maybe pass that along to other patients if you're out there with these things. If you know, have doctors that resonate with you, you know, get them to come to your support groups and talk to them, talk to the patients, because I think it really starts from the patients and what they're demanding that can help change healthcare. You know, because there's pockets of us doctors that are feeling honestly like we're a bit on the fringe, we're trying to organize, but it really comes from advocacy groups like this that give people a space and a place to talk. So when we're talking about these other symptoms and non-motor symptoms especially, can you tell us, Maya, having cared for a number of patients over the years, what do you think are some unmet needs for our patients from a quality of life? And maybe we can segue into some of the other slides that you have.
Yeah, I think that, there's a tremendous symptom burden with Parkinson's disease. And I think that we have a long way to go for really helping to manage a lot of different aspects of life. But I do, you know, one of the areas that I think I have really learned a lot from palliative care is this idea of an adjustment reaction. And so that is, you know, it's really, I think, something that we delve into in all of our palliative care visits. And what does that mean? That means that people are having trouble adjusting to a difficult situation. And that is, I think, traditionally when someone comes to the doctor and says, you know what, I'm having a lot of trouble coping, I am just really frustrated, and you know, it's you know, why did this happen? You know, I really want to continue doing, you know, my fly fishing or whatever, and I can't because my balance isn't as good as I would like it to be from Parkinson's, or whatever it is. You know, there is loss in neurological illness. We used to try to, you know, I think traditional medicine has tried to medicate those difficult feelings away with Prozac or something. So, and I still see, you know, where I get patients referred to me, and, you know, their other doctors have maybe started an antidepressant to try to help them deal with an adjustment reaction. And, you know, there's no medicine that can take away normal, difficult emotions, you know, what they call the human condition. And so, you know, our goal is not to numb you so you don't have feelings with enough Prozac. Like, that is not the goal. But the goal in, you know, helping people with any kind of serious illness information, or what we're dealing with, you know, the being so isolated, is really, one, naming and acknowledging it. So what does that look like? What are those different normal, difficult emotions that everyone in this situation is feeling. And then exploring those different ways to actually build coping and resiliency to challenge those difficult emotions. So we acknowledge them, they're there. Isolation isn't going away in this time. Grief isn't going away. When we have loss, when we lose our ability to do our favorite things because of illness, that sucks. And we get the opportunity to be angry and disappointed and sad about it. And that is just, that's how we need to deal with it, through support groups, through avenues like this, maybe, reading books that can help people, with, if someone's gone through a similar process. That connection, protection kind of idea is really important. And then, we really have people work with our chaplain to develop those coping and resiliency skills that can help them tackle different ways. If you're feeling isolated, what are different ways that you can reconnect to your breath and reconnect to kind of that inner peace within all of us as we breathe in and out, right? So there's different ways that we can kind of challenge those emotions, which we can't get rid of. They're going to be there, right? And that's how we deal with loss. And the other really, important, and so let me just maybe share what I have on that.
Sure.
I'm not sure. Okay. All right, so I just have a few things. So this is, just talks about, so these are difficult emotions that are hard to cope with. And really, it's an adjustment reaction might be like a one-time event. Okay, there was a car accident and you lost your favorite car. Okay. Or maybe there was, someone got hurt, right? That's a one-time event. With Parkinson's disease, there's chronic recurrent stress, right? As the disease progresses and you're faced with new challenges. So there's a chronic adjustment reaction that happens, right? And this might be a diagnosis. A lot of, it's hard to just have that diagnosis stay, right? And how do you deal with that? And how does that change your life? And how can you come to terms with that change, right? And still focus on things that can help you have your best quality of life. So grief, guilt, loneliness, those are the top three. And I would say that anyone dealing with a serious illness has these three. And I would say probably everyone dealing with COVID, which is everyone in the world, has these three. So these are just, common vulnerable humanity. This is our common vulnerable humanity right here. And those were words, I'm quoting Dr. Cicely Saunders, who's the founder of hospice and palliative care in the 1950s. So that's how old, from palliative care, palliative care and hospice was first developed in the 1950s. And so she really identified that these are normal things that we need to acknowledge and learn coping strategies for, not medicate away, not label as disease, right? And, this is sort of the stages of grief, right? And so you might recognize some of these in yourself when you've dealt with difficult news, denial, anger, bargaining, depression, and then acceptance. It doesn't go in this nice, neat order, right? People can jump around. They might feel, okay, they're starting to accept things, but then hey, maybe I can bargain my way out of it, right? So it's a process. It's a little bit of a roller coaster, of how we get to that point of acceptance. And this is how the human brain deals with difficult situations. We go through this. And guilt, people describe guilt as a weight, really, right? So it feels like a weight on you, right? And so there's, I hear a lot of guilt with people who have Parkinson's, might feel guilt about, maybe what they, had wanted to do with different aspects, or, maybe changes in roles in the family. And then care partners feel guilt also, because there's a sense of, there might be a sense of, I feel with care partners, they never feel like they're doing enough. Even like my SEAL team, my SEAL Team 6 caregivers are still, they never feel like they're doing enough. And so I really want to acknowledge that and say, you are doing enough. You are doing enough. And just know that it's a universal and normal feeling. Yeah. And then, just to kind of tune in to Judy's course that she's going to teach the session, and she does have longer 6 and 8 week resiliency courses that she teaches on a regular basis online that help people build resilience to these difficult emotions. And you can. And I think that this really also ties back into advanced care planning and goals of care, because, we ask people, when you look to the future, what worries you the most? Just even thinking about that, helps you address those worries. And then on the flip side, when you look ahead, what are you hoping for? What do you want it to look like? Are you hoping for more time with family? Are you hoping for more time with travel? Do those things, make them happen. There's no better time than now. And so a lot of that also just ties into, what are your goals? What are your priorities? What are your values? Really increasing those. That's how we maintain and increase that connection, protection, value. Okay, I'm gonna stop the screen share now.
Yeah, that's really powerful stuff. And I think that, we spend very little time really talking about any of those sort of things. So I think it's really helpful to kind of put it out there and just share these ideas with each other. And I agree. I think caregivers also can benefit from a lot of this sort of understanding of what we're all feeling. I think the mood, the guilt, the grief is very key. I have one quote that I wanted to, Andrea, am I able to share? I'm just going to hit share screen. Okay. I have one quote that I wanted to actually just share on the sense of guilt. Give me 1 second. I will try to share this one slide because I think it's kind of cool, given what you just put up. So Andrea, I am sharing, hopefully, screen somehow. Are you seeing the screen?
No, we're not seeing it. It's that green share screen on the bottom middle.
Yep. I have that. It's saying one participant can share screen at a time. So
yeah, if you click the middle of it, there you go.
Okay, all right. So here's a quote that I found that I put in a different talk, but hopefully you guys can see this. It's a quote by David Kessler, who writes about grief, and he has just been really resonating with me, his work. But he writes this quote about grief. So we talked about the 5 stages of grief. He actually came up with the 6th stage of grief. And I just, he just wrote a book, and this is his sort of describes the 6th stage. So I didn't want to stop at acceptance. So that's that 5th stage when I experienced some personal grief. And he actually was a grief expert. He worked with Kubler-Ross, who also is a grief expert, and then ended up talking about, a lot of this is part of his career. And then he lost his son when the son was 21, and really experienced a pretty profound loss and worked through these stages, and then came up with the 6th stage. So I did not want to stop at acceptance when I experienced the personal grief. I wanted meaning in those darkest hours. I do believe we find light in those times. Even now, people are realizing that they can connect through technology. They are not as remote as they thought. They are realizing that they can use their phones for long conversations. They're appreciating walks. I believe we will continue to find meaning now and when this is over. And so he's talking about the COVID experience, but I think it's also possibly a metaphor for some other experiences, even in dealing with some of the Parkinson's transitions and things like that. And so I think out of this darkness, I think sometimes we can gain light. Am I stopping the sharing now, hopefully? Okay, cool. So that was lovely, Maya. I just wanted to ask you a few questions that are in the chat. One is a chaplain not religious? We've been hesitant to add them because we don't want religion to be brought into it.
Yeah, I practice in San Francisco, and so a lot of people will say, I'm not religious, but I am spiritual. And so I think that, we're not talking about, some people really find their connection with this, in organized religious community. And that can be an incredibly healing gift, actually, and has, you know, I've seen just the incredible benefit that people can get, you know, with just, we just remind people, go back to your church, go back to your synagogue, go back to your mosque, go back to where, you know, wherever your spiritual leader is, and reconnect, because a lot of people with serious illness lose those connections that they had. And that for, you know, in the Bay Area, a lot of it is, I'm not religious, but I am spiritual, right? So I think that it has really nothing to do, our chaplain will say, so she's a Buddhist Jew. So I don't know.
Buju. They call them the Bujus. No, I'm joking.
A Buju, yeah. So, you know, she knows all the different religious texts, and, you know, I think she follows more of a Buddhist approach, sort of, you know, find your own answer. It's, and, you know, just kind of, she just sort of helps people find whatever that spiritual connection is to them. And I think for what she really stresses is is that a big part of it is community. Is, you know, if you can find that, you know, in addition to the connection to the greater that spirituality gives, it also, for many people, can give them, you know, connection to a really loving community. And just to make sure, if you are one of those people that have that connection, whatever it is, you know, I have a patient that really connects with Eckhart Tolle, you know, who is like a Buddhist spiritual writer. And so that's her community. It doesn't have to be, you know, one of the, you know, 4 main or 5, I don't even know how many main, you know, large religions out there. So it's whatever, it's not, I would say that it really is not about, you know, this, bringing in a specific, organized, you know, group religious philosophy, and then like pounding it down someone's throat, which, you know, obviously is a concern that, you know, I think people have. You know, we definitely have patients who say, oh, we have the, I'm happy to talk to everyone, but not the chaplain. And I'm like, okay, but she's the best person to talk to. She's the person that everyone wants to talk to the most. Are you sure? Like, just talk to her, because, you know, a lot of what, especially, you know, palliative care chaplains, their goal is to help with that existential crisis. Why me? Right? And you know, finding, you know, finding your way, helping people find their way again, and whatever that means. So yeah, I think it's very common, that concern, but I encourage you just to kind of move past it.
Yeah. I think that most chaplains who are affiliated with, you know, a program that's like a university program, you know, at the VA, for example, or in an academic center like you guys have at the UCSF, I think they're usually pretty non-denominational, even though they may have their own beliefs. And I think all of us, I mean, Maya and I have our own spiritual beliefs, as you can tell from this conversation, but, you know, I think that we are still able to practice in a state where we can treat people of any sort, of any, you know, I think in medicine, the approach is to give, you know, care to anyone who walks in your door equally, and be open-minded to, you know, the patient and their needs. And I think what you're hopefully understanding is that the patient's in the center, and all of these things are around them. And we're not just looking at the disease as Parkinson's with the tremor. It's that, you know, you live in, you know, this neighborhood in Venice, on, you know, that is surrounded by these people and your neighbors, and your wife lives with you, and, you know, this is your environment, and this is your universe, and we have to treat you, you know, with that understanding of everything that touches you that may affect your health and well-being more holistically. So, and this may not be, you know, this isn't standard Western trained medicine stuff. This is a little bit more on the outside of that box, and I think palliative care physicians are usually trained to think about the definition of health in that more holistic way, complete mental, spiritual, and physical well-being, as we've talked a little bit about. So there's a comment here about, my wife died of stage 4 bile duct cancer last July. She had an advance directive, which we were implementing. While I was doing what she wanted, I still felt like I was signing her death warrant, and that I was responsible for her death. Can you speak about caregiver spouse guilt?
I think that there's so much of grief and loss that people feel, and that first of all, I'm really sorry to hear about that, the loss of your partner. It's very, very difficult. I think that working with a good palliative care team can be very helpful. I'll give you an example. I had one of our very, very first palliative care patients. She was very, very clear with her wishes, very, very clear with her wishes. And her sons, and they'd had so many conversations, really had very similar type of feeling of, okay, but let's just put every machine possible in her that she never wanted, and just see if we can eke out one more day. And I think we had so many family meetings, for probably 3 different family meetings every single day while their mom was in the hospital, just explaining, that we didn't have a secret medicine that we were, that we could give their mom to have a good quality of life. And that, that it was time. There's a time for everyone. And that this is her time, and that she wouldn't have wanted a few more days, suffering. And that was really clear. And so, but it took 3 days and three long conversations, and we were really, patient and had those conversations and gave them that support and that time to grieve during that time. And they really came to peace with it. And one of the sons at her memorial service, he said, it's so strange, but my mom's death was beautiful. They actually had a lot of time to heal, play music together in a very peaceful setting. But it took some time for them to get to that point when they could accept that no matter what we could do, the disease was too strong. And so I think working with a good palliative care team and taking the time to have those conversations is really what's needed for people.
Absolutely. And I think even after somebody passes away, sometimes there's still a need to connect with, possibly a chaplain, possibly a psychologist, possibly get some, conversations still with the family that's still there. It is not, a one day, move on with your life kind of situation. I think all of these reactions, adjustment, grief, guilt, all these emotions are so human. This is part of the human condition. They're all normal. You are not alone. This is not the first time that anyone has had these discussions. And so I think, being honest about what you're feeling and communicating that with the team, I think is very helpful. And I think that that's really important. One of the questions was, about do you have a recommendation on people with a lot of pain due to Parkinson's, but it's not a good candidate for palliative care?
Well, I would say that everyone is a good candidate for palliative care. That there's always something more that we can do to help, whether it's sitting down and praying, or whether it's teaching a mindfulness technique that can refocus the brain away from a painful sensation, or whether it's, a new kind of lidocaine gel that's really effective for treating the pain on a certain part of the body. There's always something more that palliative care can help with.
Yeah, I think that we've branded palliative care in such a way that the last question here is palliative care only for people who are end of life stage, or is it available to everyone with PD? And I think we've branded it as such a last ditch effort, but I think it's very different. And maybe you could just speak in the last couple minutes to that. And I think just before we go there's been a lot of specific questions about forms and when, who, what, where. They're quite different in each state and different forms. So I think the PMD Alliance are going to do some more specific forms sessions, and with the social worker and some other folks moving into, I think, July. Maybe you can put up those resources and the plan for that, because I don't want to ignore those questions, but I can't speak to individual ones. And I definitely know that there are some coming. There's also been a lot of resources posted just by you all in the chat here, and I want to capture some of those. I don't know some of these. Ambiguous Loss, Knocking at Heaven's Door. I just mentioned the one by David Kessler. So I think there's a number of books, and if people have really found something that speaks to them, somebody's talking about Barbara Carnes. There's, I think we can maybe just share them and then maybe have a separate chat about this, and in a different session, maybe led by one of the social workers. I think there's a lot of rich information in the chat that I don't want to ignore. So maybe just speak to that one issue, Maya, of trying to get palliative care, you know, drizzled in maybe earlier and just end of life, and then maybe close with something that you might want to say about a silver lining or something inspirational.
Um, so I think that, you know, palliative care was developed by Dr. Cicely Saunders when she developed hospice and the entire philosophy of it. And then, you know, over the past, I would say 30 years, well, since the 1980s and 1990s, we've discovered that actually whole person care shouldn't just be for end of life. We can actually take care of the whole person from day one. And that we actually should see people as whole people from day one, and that the entire medical education and clinical care needs to change to accept that. And it will. This is the future of medicine. Nobody goes backwards, you know, to less holistic care. And so this is what's happening. You know, this is you know, this isn't a new concept, but it's still on the fringes, but it's moving forward at a fast pace, and you'll see it more and more of it being available to you at all points. And I think what I'll leave with is that, you know, I think we talked a lot about, you know, some difficult things, and I would just, you know, just flip it and just say, you know, with your time ahead, just use this, you know, as a springboard to think about what are your hopes and goals. You know, as you look ahead to the future, what do you want your life to look like, you know, in the next months, years, decades, you know, however much time each of us have left, we don't know, but we can think about and really kind of and focus on our goals and values and priorities and our hopes, and building those connections to really focus on our whole person health for the whole people that we all are. Right.
Absolutely. Well, thank you so much, Maya, for joining me. You're lovely as always, and I want to hear that rough viola sometime. I got to look up some of those videos. That's just comedy on so many levels. I can't even picture you doing that. But anyway, so Johnny wrote from his iPad, "This was great. You two should start a podcast. I'd tune in weekly to hear your chat." But you definitely have some spiritual leader in you. I see that in you. So maybe, I don't want you to leave medicine, but you know, there's definitely some very wise words in there, Maya. So I really appreciate you bringing them to us. And we'll have Judy on here, who I think you learned a lot from as well. She'll be coming on in the next few weeks. So we'll continue this discussion. Thanks again to the PMD Alliance, and handing it back to you, Andrea.
Yes, thank you to both of you. There were so many resources shared, and we do have, like Indu mentioned, some more pieces where we'll go into, in detail, healthcare directives. We're going to do something on the 5 wishes, and that's going to be in July. Then we're also going to have Judy Long, the chaplain, and Dr. Benzie Kluger. So I think what we'll do is, to everyone who registered and is here today, send a follow-up email, because there is just a wealth that, and everyone who's here, I think you're seem really interested and want to hear more and learn more. So stay tuned for that. And what a wonderful way to, learn more about this topic. I'm going to rewatch it. The recording will be up by the end of the day. I think all of us, are just, our minds have expanded today. So with that, let's wave each other goodbye. It was so good to learn with you all, and great questions, everyone. And thank you, Dr. Katz and Dr. Subramanian. Bye, everyone. So glad to be part of this virtual community with you.